अपन तो चेक ही क्या काम कर रहा अपना ईयरफोन काम कर रहा है ना.
Hello.
Yeah, good afternoon.
How are you?
I'm fine. How are you?
Okay lah, huh? Hi, Amit. Yeah.
Hi.
It's terrible lah, the COVID. Yeah.
Yes.
All of us are struggling to cope with it. Yeah. Otherwise, you look good lah.
How is the condition in your place?
We all been deployed to actually cover the COVID wards. Yeah. There are a lot of workers which have the COVID, but the coronavirus. But otherwise, we just restarted the rehab facilities. I think the neurosurgeons also started doing electives now, so it's getting better.
Maybe we are getting used to it, if not better.
Yeah, maybe getting used to it, but it's been too long. Yeah, I just want to finish it as fast as possible.
Yes.
Yeah, right. Yeah.
Welcome, Professor Angelo.
Okay, good morning. Good morning, everyone. Okay.
Hi.
How are you, Angel?
We in Italy are well. You in India
Yeah.
with the COVID problem.
How is your place now? In Italy.
Okay. When we start an half past 11, I think, no?
We would be starting at 3.
Oh, if you want, we can also start now. No problem.
Now what we can do is we can show one slide of our presentation just to make sure that things are running well.
Okay.
And what we have decided on is it would be a 20-minute lecture and followed by 5 minutes of questions. I would be taking the questions as text message, and then I would be asking on behalf of the participants.
Okay.
Plan like. So maybe Professor Angelo, if you could show your first slide.
Yes, now. Okay.
As a trial run.
Just a moment.
Yeah, that's.
You see?
Yes, it looks
it's
good.
good for you. Okay.
Yeah. Fine. Fine. Perfect. So
I go out. Okay.
Yeah. And
Yes.
Professor NGCN, if you could show your first slide.
Sure. I think it's this one. Is it okay?
Yes, it's okay. Yes.
Okay. All right. Okay.
So now we are waiting for the other two participants, Dr. Girish Menon from Karnataka and Dr. John Solomon. So I suppose they would be joining shortly.
Prof Sinha, are you in Jaipur now?
Pardon?
Are you in Jaipur or are you traveling in India or you're in Jaipur now?
No, Jaipur.
Jaipur. Okay.
Last travel I had in February.
Oh yeah. We all cannot go to a country anyway. We all stuck. We can't even leave Singapore. Yeah,
Only
it's quite terrible. Yeah.
By car we move from one city to other city nearby.
All right.
Yeah. And how you move?
No, I cannot move. We are since February. The airport is closed. So we are stuck in Singapore for some time to come. Yeah.
And nowadays I started fearing flying in the plane because I don't know how pilot flies now.
Not sure. Yeah, it's quite.
We had an accident in India.
Yeah.
I go in Paris on January, and after I stay home all this time. See, Paris is the last my thing that I see. Okay, but it's a beautiful.
Actually, none of us had imagined that the whole world would be facing one common problem. Never in our lives we thought that the entire world would be facing one problem. It usually it's every country facing different problems.
Yes, yes. We start with the problem in the world, okay? In Italy, we start with the problem, and now we stay well, quite
Yeah, I
well.
must congratulate. I mean, in Italy, you
Italy
all
did
have
very
done a
well.
marvelous
Yeah.
job. Yes. I suppose in Italy, have we reached some kind of a herd immunity or something like that?
Okay, we wait.
Don't know.
Okay, Amit, I'll come back in 10 minutes time, if that's okay with you. Yeah.
Fine, fine. Yeah, yeah.
Sure.
I think we can have a cup of coffee and then
Okay, yeah.
join
Thanks.
back. Fine. So we meet again maybe 5 minutes to 3.
No problem. Okay.
So maybe exactly 15 minutes from now.
Sure. Okay. Thanks. I just clear some work first. Thank you.
See you.
Okay.
Okay. Bye-bye.
Dr. Angelo?
Yes.
Which hospital you work?
Excuse me, I don't understand. Just a moment. I can leave now the meeting and come back in half an hour.
Yeah. It is about not half an hour. It's about
at 30 past 11.
20 minutes. After 20 minutes.
Okay. See you later. Ok?
Ok.
Beh. Come faccio a lasciare qui? Dice che ci rivediamo più tardi. Quindi... Quindi poi io vado condivisione schermo e parto la cosa. Non sento loro però, stranamente.
Forse loro non hanno l'audio.
Partecipanti 17 sono quelli che si sono iscritti. No? Allora sì. No, li vedo fermi. Sì, c'hanno l'audio, questi due c'hanno l'audio spento e se lo devono riattivare loro. Che cosa possiamo fare? Noi non possiamo fare niente. Ok, tu sei al posto di...
John Solomon.
Yeah.
Dr. John Solomon, are you able to hear me?
Yes, sir.
Yeah, good afternoon.
Thanks, sir. Afternoon, sir. Thank you for this
Yeah.
opportunity.
So you are not, your
The video
voice
is open
is
here, sir.
not really clear.
Is it, sir? Okay. Let me check.
Yeah, Professor Menon, welcome.
Welcome, sir. How are you?
I am fine.
Oh,
I am
Girish,
fine.
how are you, Girish?
Fine. Thank you, sir.
Yeah.
All well, sir?
Yeah. Please, could you show your first slide just to have a trial run?
Telling me?
Yeah, Professor Menon.
Yeah. Just a moment.
Dr. Solomon, we are unable to see you. Your video has stopped playing.
Is it coming?
Okay.
Yeah, in the presenter view.
Yeah, just a moment. Yeah, can you see my screen? I'll
Yes, I can see your
make it into a slideshow. Just a moment. Is it okay?
Yeah, this is fine. Perfect.
Okay, so I'll exit. I'll stop sharing.
Yeah. Dr. Solomon, if you could show your first slide.
Hi. Just a moment.
Dr. Solomon.
Okay.
Dr. Solomon, question here. Disconnected. I suppose Dr. Solomon is having some internet issues. Anyway, we are going to start shortly in another 1 or 2 minutes. Professor Sinha would be giving the introductory note, followed by Professor Angelo. You would be the first speaker of the day.
Yes, okay.
And Dr. Girish Menon, you would be following him. And then Dr. Solomon and Dr. NG CN, you would be ending the show. So I suppose
Shall I share the screen, sir?
Yeah, please, if you could show the first slide. We would try to keep the lecture in 20 minutes each speaker so that we get the maximum attention span of the participants. It would be followed by 5-minute questionnaire.
It will be great, yeah.
Dr. Solomon, I am unable to see your screen.
Coming now?
Yes, Yes, I could see it. Yes. Yes, I can see it. Okay. Fine.
Yeah, I'll stop sharing now.
Fine. ठीक है, we'll start. ठीक है, start कर लो. 41, start कर लो. Okay, so we would be starting now. We would be opening the lines. Fine. Over to Professor Sinha.
Yes. Good afternoon to everyone. And on behalf of wfns, Neuro Rehabilitation and Reconstruction Neurosurgery Committee and AASNS, I welcome all the speakers and the attendees on the webinar. We treat a lot of TBI every day, but because of we don't have good facility of rehabilitation in most of the centers, so outcome of this patient is not as what we think it should be. So this is a very important seminar. So we will know about the how to rehabilitate the patient after TBI, and all big persons are here and they will share their experiences. So I give this screen to Dr. Amit, who will coordinate the webinar. Webinar will be about 20 minutes plus 5 minutes for discussion. So now, Dr. Amit Chakravarti.
Thank you, Professor Sinha, for the nice introduction. And so today we start the presentation. The first speaker of the day is Professor Angelo Lavano. He is head of the Neurosurgical Department, Functional and Stereotactic Center, University of Magna Grecia of Catanzaro, Italy. He would be talking about the technological advances in spinal cord stimulation for pain. Professor Angelo, over to you.
Okay, you see, hold. Can I start? Okay. Yes, just a moment. Okay. The speak is about technological. Just a moment. Oh. Okay. We speak about technological advances in spinal cord stimulation for pain treatment. And the epidural spinal cord stimulation is probably the most commonly performed surgical intervention for pain. And it started in 1967 but with the Chile, and the system evolved in conceptual and practical dimensions. But this, despite the progressive improvement in leads and the IPC, the outcome of spinal cord stimulation have been characterized by limited success rate and limited quality of life and a decline of efficacy over the term. In the last few years, dramatic advancement in technology increases skill to tailor individually the pain treatment to each patient's unique need. And this is the concept of appropriateness. What means appropriateness of a system, or what is appropriate for healthcare? Appropriate care means the selection from the body of available intervention that has been shown the best efficacy for a disorder of the intervention that is most likely to produce the outcome desired by the individual patients. And now it is possible to define among the devices current available for spinal cord the most appropriate system for the patients, and the technological improvement made in the context of spinal cord stimulation have made this possible in clinical practice. And this is a paper that is the Neuromodulation Appropriate Consensus Committee that show all these situations. The technological advances, the new technological advances were in stimulation waveform and in the device. And now we see this improvement the new technology of stimulation waveform. Since today, the stimulation was a conventional stimulation that involved tonic electrical stimulation at moderate frequency, 40, 60 hertz, with the goal to excite the large diameter sensory efferent in the dorsal column to create paresthesia. And the paresthesia occur rapidly and serve to a surrogate for pain relief that make it practical to test several sets of stimulation with a standard clinic twist. But the success rate that is defined as a proportion of patients receiving 50% of pain relief is approximately 58%. And sometimes the evoked paresthesia can be unpleasant or annoying for the patients. So new stimulation waveforms were studied, and one is the bar stimulation that are intermittent short brain of closely high frequency electrical pulse stimulation. And this mimic the thalamic bursting within the nervous system. The advantage of this waveform over conventional spinal cord stimulation is improved pain relief, and it is a stimulation, a paresthesia-free stimulation, because the stimulation is at lower intensity below the threshold of A-beta fiber activation. You can see here two papers. One is published on neuromodulation. One is the success is about 60% of patients, and but the evidence basis of the systematic review of bar stimulation is considered until now fair and limited. The bar stimulation I work with different mechanism in front of conventional spinal cord stimulation. It's possible that bar stimulation made a more selective modulation of the medial pathway, pain pathway, with activation of the dorsal anterior cingulate cortex. So with a improvement also in affective component of pain. The other one is the high frequency stimulation, that is a stimulation at 10 kilohertz stimulation with 13 microsecond pulse width and current of 0.5 to 5. Also, this kind of stimulation have advantage like improvement pain relief, and also this is a paresthesia free stimulation. Some paper documented that this kind of stimulation is better both for back and leg pain. And you can see here a paper that confront the result between tonic high frequency bar stimulation and the bar stimulation, the high frequency stimulation are potential solution for the uncomfortable paresthesia problem of conventional spinal cord stimulation. And they have a better success on axial pain with these two kind of stimulation. But in paresthesia-free, stimulation parameter efficacy can only be determined by patients' reported pain relief after several hours of stimulation. So the ideal system is a single system, a single implant that should be able to deliver all modality of spinal cord stimulation. The innovation in the device concern technology advances in lead and in neurostimulation. In lead, there is the high density electrode array, the percutaneous spinal cord stimulation paddle lead, and the dorsal root ganglion stimulation. The high density electrode array is the increase of the number of the electrode in the lead and improve the lead design. These have shaped, shape the electric field to optimize the neural selectivity and the possibility to target different spinal level and to allow high number of stimulation configuration. And paddle electrode arrays also include 2 to 5 column of electrode that improve the mediolateral resolution of the stimulation. The implantation technique, we think that percutaneous technique should always be the preferred first opinion to implant a lead with the percutaneous lead. The implant indication for a direct access to open epidural space are inability to access to the space, the previous laminectomy or intervertebral fusion that prevent access to the posterior space, and when the percutaneous lead not made possible optimal paresthesia coverage, and when the circumferential stimulation of the percutaneous lead causes important indesirable effect. But also the main problem is when percutaneous lead has been effective for and frequent dislocation. A new concept is the percutaneous spinal cord stimulation paddle lead that is a system, this is an epiducer that allow to introduce multiple leads, also paddle leads, into epidural space below the L1 vertebra without the laminectomy. These have the consequence to allowing one-time access to the epidural space for the placement of multiple lead, also for paddle lead. And you can see here the epidural system and the possibility of the different electrode implanted. Another possibility is the dorsal root ganglion stimulation. It is a low frequency paresthesia-based stimulation. It consists in implantation of cylindric and electrode in the epidural space of a neural foramen in proximity of the dorsal root ganglia with focal stimulation effect. Because the stimulation is targeted at individual dorsal root ganglion, is extraneous stimulation in a non-painful area is substantially reduced. The use of dorsal root ganglion stimulation increases lead stability, less postural variation in paresthesia, and reduce the lead migration. Dorsal root ganglion stimulation is made with a lower stimulation amplitude because the electrodes are placed close to the dorsal root ganglion. And this therapy is efficacy in any body or region of the body, so long as the area behind treated is focal and not widespread. Innovation in neurostimulation capability concern the closed loop stimulation, the MRI compatibility, the rechargeable IPZ, the multi-wave technology, the multiple independent constant current, and the steam wave technology. Here you can see the 4 kind of stimulator now available on the market with their different characteristics. The closed loop stimulation is a technology to measure the spinal cord effect of SCS and automatically adjust the strength of its stimulation to keep the therapeutic stimulation constant. It's based on 2 kinds of stimulation. The 3-axis accelerometer with the sensor drive position, and the other one is evoked compound action potential. That stimulation is kind of stimulation that change the stimulation with the change of body position that alter the location of spinal cord within the vertebral canal. There is a 3-axis accelerometer that senses patient's body position and automatically adjusts program cycling between pre-select setting chosen for each position or activity. The new one is the ECAPS closed loop stimulation. ECAPS means evoked compound action potential that are generated during spinal cord stimulation and reflect the summation of individual action potential generated by an spinal cord stimulation pulse. And ECAPS can be recorded using inactive electrode in the spinal cord stimulation array, and its amplitude can serve as a control signal related to SF, spinal cord stimulation efficacy. And movement of the spinal cord with respect to the stimulation can lead to subtherapeutic stimulation or discomfort, usually. And the stimulation amplitude with this system can be automatically adjusted using the ECAP amplitude to maintain stimulation within a therapeutic range. Here you can see one of the first study with this kind of simulator that is under development. Another concept is MRI compatibility, but is conditionality, not compatibility. More of the spinal cord implanted patients are expected to need a new MRI within 5 years of implant. But the possibility that energy used by MRI could cause induction heating of the electrode, unwanted stimulation, movement and displacement of the implanted system, and irreversible damage of the EPG. The new kind of system, in the new kind of system, different EPGs, extension and electrode, are full compatible with the MRI, with a power of 1.5 Tesla. And because they have a magnetic shielding for protection. But the new concept of MRI compatibility is the MRI conditionality. The MRI conditionality is for a spinal cord stimulation that have demonstrated to pose knock-no hazard in a specified MRI environment with specific condition of use. So the new classification is MRI safe, conditional, and impossible. New possibility to have a long lifespan of the device is obtained with rechargeable neurostimulator. That the lifespan is from 2-3 years, that now became 8-10 or more years. This kind of stimulation had also a significant reduction in size of EPG. And they offer also the possibility to use architecture of stimulation delivery based on the intensity of the current delivery and not on the voltage used, with allow a precise and adjustable stimulation delivery as it is not affected by impedance. Also, there is a reduction of the cost of in the long term of therapy. Another possibility is the multi-wave technology. A single system provides multiple waveform and field shapes to customize therapy and improve efficacy. The delivery of multiple waveform, this conventional burst and high frequency, intended to help respond to change in pain over the time. And can be utilized simultaneously or to treat a single area, simultaneously to treat multiple areas, and sequentially to address habituation. A new technology in new neurostimulation is the MICC, multiple independent constant current. That is the delivery of controlled current for each single electrode of the lead. And each electrode is guided by an autonomous current source, and the current can be varied independently on each electrode. This is the fractionalization of stimulation. Also, it's possible to have a steer ability of electrical field and stimulation, both longitudinally on the single lead and transversely on the two lead or column. And the MICC had a complete flexibility in administering the most suitable electrical therapy to the individual patients. The last possibility, and the new last possibility, is the steam wave technology. That is a delivery of a waveform, both tonic, burst, and air simulation without a pulse generator. There is a wireless powered micro-size multi-contact neurostimulation device that contains telemetry unit and energy receiver inside the lead. Power source is located in an external device that utilizes a high frequency transmitter. And this system is MRI compatible. You can see here the lead with the antenna and the circuit, and this is the introducer, and this is the external power source. In conclusion, we can say that spinal cord stimulation is a dominant neuromodulation modality in the treatment of pain. It is a long history and plenty of documentation to support clinical effectiveness and safety of spinal cord stimulation. The new technological and conceptual developments are expected to translate into better outcome and improved quality of life. Wider choice of spinal cord stimulation system today available will allow to tailor the pain treatment to each patient's unique need. Thank you for your attention.
Thank you, Professor Angelo, for giving us such a nice bird's eye view of spinal cord stimulation and its technological advances. We have one question from Professor Sinha, that is there any role of CT scan for assessment of patients who require spinal cord stimulation or not? Or it is just based on MRI and clinical practice?
No, with the CT scan there is no problem, but there is a problem with the difficult to have a good imaging with the CT scan. The problem is only with the MRI.
Okay.
And sometimes CT scan can help to introduce the lead, the percutaneous lead, when there are some difficult for anatomical variation of the vertebra, of the column.
Do these electrodes cause any artifacts in MRI when we want to really assess the residual compression? Does these electrodes cause some artifacts?
In the MRI, there are also some artifacts for the lead, but the new leads are compatibility with the MRI, and the artifacts are less. Okay, one of the problem, if I can say one thing, is also the possibility that with the paddle leads there will be a big scar around the paddle lead that may have a compression effect on the spinal cord. This is really a problem when you put the lead in the cervical or dorsal region. Sometimes we have to take away the lead and the fiber and the fibrous tissue around the lead for a compression on the medulla, on the spinal cord after few years. Okay, this is for paddle lead and less for percutaneously.
Thank you, Professor. So over to the next speaker. May I welcome Professor Girish Menon. He's a professor and head in Department of Neurosurgery, Manipal Academy of Higher Education, State of Karnataka, India. He would be talking about rehabilitation following epilepsy surgery. Professor Menon, please could you deliver your lecture?
Thank you, Amit. Can you see my screen? Hello, Amit.
Yes, we can
see my screen, and am I audible?
Yes, you are audible. Yes.
Thank you so much, Dr. Amit, and thank you so much, Dr. Sinha, for this opportunity. I would say both for helping me to speak, but more importantly, for this opportunity to learn, because this has been quite a learning experience for me preparing for this talk. And I will tell you why, because I'll just start off with a small introduction about myself and the topic. Epilepsy surgery, if you look at it, has had a checkered history. It started off with a bang. You would all remember how the phenomenal work by Wilder Penfield and so forth. Then there was a dip, and then it has a surge. In fact, in this century, the latter part of last century and this century, in fact, epilepsy surgery has been convincingly proven to be effective, and it has become the standard of care for many cases of medically refractory surgeries, epilepsies. I had the fortune of being associated with one of the giants of, I would say, the renaissance of epilepsy surgery in India, that is Professor Radhakrishnan at the Sri Chitra Tirunal Institute in Trivandrum, where I used to be part of the epilepsy surgery team when he started off this process of revamping the epilepsy surgery program in India. Subsequent to that, a lot of other centers have taken over epilepsy surgery, and it is being done in many centers all over the country now. But I had the good fortune of being associated with him. And in fact, since his retirement, he works in a small center in North Kerala, where I go and assist him periodically even now for epilepsy surgery. So the topic which I have chosen, in fact, is I've chosen it deliberately because even my outlook towards outcome of epilepsy surgery has changed over the years. For me, and as I would believe for many of us who are into epilepsy surgery, even the epileptologist, we used to think it is all about seizure control. But then we realized slowly that it is not all about seizure control. That's why I chose this topic. So I did a bit of research on this and my practical experience together, and that's what I would be I will be planning to share with all of you today. So it's in fact a neglected entity because we give so much of thrust and so much of importance to workup for epilepsy, the surgical approaches, the surgical techniques, the intraoperative monitoring, and so forth. In the bargain, we miss out on a very important role of neurorehabilitation in epilepsy surgery. Now, as I said, epilepsy surgery is here to stay. And why so? There are a lot of series, a lot of original series, but it has been these two phenomenal randomized control trials, which is always considered the benchmark for any new drug or medicine or any approach. The one published in 2001 in the New England Journal of Medicine. This was the first randomized control trial comparing surgery versus medical management for refractory epilepsy. And you see, there's no doubt at all, 58% seizure control in the surgical arm, whereas 8% in the medical arm. This was followed by this randomized control trial published in the JAMA, which is as late as 2012. Again, you would find overwhelmingly and convincingly proving that you can see here the medical group seizure control was almost zero out of the 23 patients, whereas in the surgical arm it was 73%. So both these studies, I would say, were kind of control trials were prematurely stopped because of the overwhelming result in favor of the surgical arm. So there is no doubt that surgery helps. And to what extent? If you look at this graph from 0 to 100%, of course, it can't be 100%. It is neither 0%, but there are different some categories of epilepsy surgery, like the curative surgery or the resective surgeries, the temporal lobe resections, commonly done for mesial temporal sclerosis, the lesional surgeries, the hemispherotomies, where you get a result of almost 70 to 80%, almost bordering to 100%, but not 100%, but definitely somewhere near there. Then you have something in the middle, the extratemporal resections, where you have around 50 to 60% success rate. And then, of course, there are these palliative surgeries, the disconnection surgeries, which we call the corpus callosotomies, the multiple subpile transections, the vagal nerve stimulation, so forth, which the success rate is far less compared to the resective surgeries. Nevertheless, it is undoubtedly effective in a carefully selected optimal patient. What are the risks of surgery? I would say not much. If you look at over here, even for invasive monitoring, resective surgery, mortality altogether, it's around 1 to 1.5%, quite acceptable rates compared to the trauma which these two patients undergo. So does that mean that in a carefully selected patient, you operate and the seizures are controlled, all epilepsy surgery patients become happy? The truth is far from there. And why is that so? Let us look at the clinician's perspective of outcome. Whenever we write, an epileptologist writes or a surgeon writes about this outcome, it's all about seizure control, whether the patient is drug-free after the epilepsy surgery, so forth. And if at all there are lacunae, it is all brought up, it is all pointed at follow-up issues, loss to follow-up patients, or the mixed temporal, extratemporal lesions. That is why the results are not optimal, or because the standard classification of seizure control is suboptimal, so forth, so many reasons. This is the problem. Only seizure outcome is often reported and given so much of importance to. So this is the clinician's perspective, but let's look at the patient's perspective. Look over this bubbles here. Persistent seizure is just one aspect of his whole lot of problems. He has a whole lot of problems which results from side effects of medicines, the cognitive problems, his mood problems, restricted quality of life, and so forth. So what the patient aims at is he wants to be seizure free, he wants to be off medicines, he wants to be independent driving, he wants to have a happy married life, employed, and he wants to merge with the society. And this is one aspect which, as surgeons, epileptologists, we tend to miss because we are chasing that figure of seizure freedom. So this is a beautiful pictorial depiction of what an epilepsy surgeon wants to. He just wants to get rid of this nightmare called epilepsy. He wants to be awake. He wants to have a good quality of life. That exactly is what, as a team of epilepsy surgeons, we ought to look at. It's not about seizure control. It's not only about psychological outcome. It's not about psychiatric outcome, educational or occupational outcome. In total, it needs to, there is a focus should be on improvement of quality of life, and that should be the prime target. So what are the challenges? As I said, it is not only about pointing the localizing the exact focus of being concordant case and then resecting surgery, doing a resective surgery or whatever it is, intra-op monitoring and so forth. Let us look at this is a terminology which I'm sure those who into epilepsy might know about it, but many might not know. The burden of normality. What happens once you operate and the patient becomes seizure free? We feel everything is fine. Why should the patient crib? Why should he be unhappy once the seizures are done and he's off medicines? It's not as simple. There's something called the burden. This is what has been described as the burden of normality. The patient has a lot of psychological issues. The sense of cure and his need to prove that he is normal, increased expectations from his peers. More important, the lack of excuse. Quite often they get away with this excuse of being of an epileptic patient and so forth. So there's a whole lot of challenges with these patients face. There are behavioral changes. They tend to overdo it. They tend to underdo it. Affective changes. can range from extreme euphoria to extreme frustration, and of course sociological changes, need for employment opportunities, and so forth. What I want to highlight over here is it's not about being seizure free, not about being drug free. These patients have a lot of other psychosocial aspects which will persist in spite of them being seizure free after surgery. So one is the burden of normality, and the most important parameter which many of them complain, in fact, employment opportunity is one of the most important reasons when many of them opt for epilepsy surgery. Being employed is being socially accepted, being the breadwinner of a family is so much more important, very important. So this was this interesting study done in my alma mater, the place which I was mentioning, in Sri Chitra Institute, Trivandrum, where they analyzed the employment outcome and satisfaction after anterior temporal lobectomy. Anterior temporal lobectomy being one of the most common epilepsy surgeries which is done all over. And this is the summary. What they arrived at, they found that the outcome in terms of employment opportunities at best modest, and it may take several years after surgery. Freedom from seizures achieved by ES, means epilepsy surgery, does not always translate into useful employment. So very, very important take home message here. Just by being seizure free does not mean that the patient gets gainful employment and he can merge with the society. What are the reasons for this? Could be memory, emotional disturbance, as I said, the burden of normality, which many of them have, poor self-esteem, which has been over there for many years, and of course, employer discrimination, which is so very much common in developing countries like ours. This is another interesting article which I wanted to share with you. This is I would say, a randomized control trial again, or on epilepsy surgery patients, done by the social scientist Rupert Tobeck. What they did is employment outcome 2 years after temporal lobe resection, temporal lobe surgery, epilepsy surgery, in a group of 232 patients. So they had one group who were given rehabilitation program and the others who were not given the normal thing which was being done before. So a small group was given, a group of 119 were given an intense rehabilitation program. And this is what the program included. Of course, optimization of medicines, and there was psychiatric counseling, epilepsy nurse counseling, physiotherapy, sports therapy, occupational therapy, so forth. And this was this huge team that was involved in this rehabilitation. It's not the neurologist alone. The surgeon doesn't figure it all. Of course, his role kind of ends after the surgery. Epilepsy nurse, the physiotherapist, sports instructor, psychologist, clinical psychologist, speech therapist, social worker, so forth. So this is the team. This is the team which is needed. And these were the determinants. Of course, he found this. What are the determinants which kind of decide whether the patient is going to get employed or not? Younger the age, better the chance. Personality disorder, negative. If you're employed before surgery, there's a better chance of getting employed later on. But here, a specialized rehabilitation program with a comprehensive interdisciplinary approach may improve employment outcome after temporal lobe epilepsy surgery. This very important message was driven by, through this, again, I would say, a randomized control trial. But there's a cautionary note at the cautionary footnote. Rehabilitation is only one of the several factors that influences outcomes. Just rehabilitation alone won't suffice. It has to be a team effort. What are the other areas? What are the other challenges which epilepsy surgery patients have after surgery? And especially most studies have been done on temporal lobe epilepsy. Here you can see the memory decline which they have. Good proportion of them are seizure free, 67% you would say are seizure free, but look at the memory problems. Almost 37.8% have a decline in memory, of which 10.2 have a significant decline. So, and then there's this 12.3% who are neither seizure free, but their memory is down. There's a double loss, big loss for them. What about speech? Especially if we compare right to left, there's another study, beautiful study, which compared right versus left anterior temporal lobectomy patients using the Boston naming test. This is their results. Post-operative decline in naming failure was noted in almost 41.6% following left. These are subtle changes which miss quite often in the review follow-up, when we see these patients, we just end up talking to them about their seizure outcome, optimizing the drugs. These small defects in naming and memory we often ignore and tend not to look into. Attention disorders, again a huge problem which many of them have, especially following left anterior temporal lobectomies. It could be specific to epilepsy, it could be non-specific to epilepsy. But again, some small changes quite often help. In this study here showed a lot of drugs like the sodium valproate, the phenobarbital, the phenytoin, this have a negative effect on attention. In fact, the newer ones like the levetiracetam and so forth are much better in that. Just drug optimization would quite often solve this problem. And of course, there's no question the role of cognitive rehabilitation and antidepressive drugs and psychotherapy. Now, cognitive rehabilitation, I must confess, even I have a very limited knowledge about this, but this is what I found during research, and I'm sure there would be some experts among the listeners today. This has such an important role following epilepsy surgery. This is such an under-researched. This paper here tells us that cognitive rehabilitation is such an under-researched, under-reported aspect of epilepsy surgery, and that needs to be revived. Immediate effect rather. The visual defects, of course, this is a major problem, especially after temporal lobe epilepsy surgeries. You know the Mayer's lobe quite often gets affected, and all these patients are left with a quadrantenopia following surgery. More important than the quadrantenopia is their inability to drive. And this is so very disabling. If you are left with a quadrantenopia, a person who was driving before might be left not able to drive following surgery. So all the goodwill that you gain by controlling a seizure is lost just because of the fact that he can't drive following surgery. This is another major challenge, the psychiatric problem and the suicidal tendencies, which this paper which compares the control arm, the medical arm versus the surgical arm in terms of mortality. It is not the ones directly related. So in all aspects, surgical arm have a higher rate of mortality. Some related to seizures here, and those unrelated to seizures. And what I want to highlight is this one here, suicidal tendencies. Sorry. You would see almost 4 of this 319 patients had in the surgical arm committed suicide, none in the surgical arm. It could be varying reason, but as I mentioned in the burden of normality, a lot of them, in fact, we had one patient in Sri Chitra where the patient committed suicide when the seizure was totally well controlled. They just never know what goes through their mind, and probably with good rehabilitation and with counseling, we could have averted that. So enough data to suggest that the suicidal tendencies after resective epilepsy surgery is something which is very important. And the footnote here, the suicide may occur after epilepsy even when patients have excellent seizure control. So it's not all about seizure control. The focus has to shift from seizure control in terms of epilepsy patients. Then there is this problem with sexual desire and satisfaction. This is again another paper from my old alma mater, Sri Chitra Center, where it shows that sexual dysfunction is another underreported, under-discussed topic, very common, especially with mesial temporal lobe epilepsy. It might improve to some extent following surgery, but not satisfactory. So what needs to be done for these? How should we kind of revise our epilepsy surgery protocol, pre-op assessment, and so forth? Present day neurosurgical pre-surgical evaluation is so very systematic and methodical. I'm sure all of you know about it, the clinical, the EEG, the intellectual EEG, neuropsychology. Here again, I would say all the neuropsychology is done. It is very limited just to probably look at his verbal memory and his non-verbal memory. Very seldom we do a detailed psychosocial analysis and find all his other problems which I listed earlier. Then of course we have functional imaging, the PET, the SPECT, the stereo EEGs, invasive monitoring and so forth. A lot of non-invasive ones, the invasive ones, so much of emphasis, so much research on finding out the epileptogenic zone prior to resecting that. Then you have the 7 Tesla MRIs, the DTIs, stereo EEGs, so forth. What is often lacking is a detailed psychosocial analysis. Something unfortunately many of the epilepsy surgery centers, including the one which I was I'm involved, I should say, this is one area which we kind of neglect. We feel it is not important. We feel it's all about seizure control. So of course, so the most important is we need to have a detailed psychosocial, psychological analysis and before surgery itself. This entire thing needs to start before surgery. Quite often we might not decide to operate on a patient. Probably seizure is just one part of his worry. Then of course the careful patient selection. So all said and done, seizure control is important. And as you said, as seen here again in the study from my center, the seizure freedom with or without AAD, these are the ones who have a better quality of life. So quality of life, definitely seizure freedom is an important parameter, but what I'm trying to emphasize is that that is not the only parameter. So trying to conclude, so take home messages are that 2/3 of carefully selected epilepsy patients can become seizure free. Seizure outcome is just one of the measures. Quality of life is the whole. We need to look the patient in total, not only seizure freedom or drug freedom. Long-term outcome, long-term psychosocial and occupational counseling support is extremely important, and the process of rehabilitation needs to start much before surgery. So very important for a lot of epilepsy surgery centers. And this is some of the aids which we need to. This is someone which I've just copied from a recent article, and this just gives you the broad direction in which we ought to look into. First, develop a rapport with the patient, some form of psychoeducation, self-monitoring devices, external memory aids, internal strategies, practice, homework. So along with the pre-surgical workup, we need to start this well before surgery is done. Just lifting all the other aspects, the same thing, detailed pre-op psychosocial assessment, anticipate the expectations of the patient and the family. We need to target the patient's expectations. It has to be patient-centric rather than the epileptologist-centric. Discuss key issues before surgery, and most important is a multidisciplinary review, which is the last point which I have written here. So as I showed earlier, it is not a single person's effort. It's not the epileptologist or the epilepsy surgeon alone. It's a huge team effort. Only then could we kind of reach some kind of satisfactory outcome. Thank you so much.
Thank you, Professor Girish, for such a nice presentation. It has been much admired by many of our participants. I have been receiving messages, and many have appreciated your lecture. One very interesting question which has come up is, driving is of course one of the major concern for most epilepsy patients. Do you have any protocol to give them some kind of a green signal for driving after epilepsy surgery? How long do you wait?
Yeah, unfortunately, like some of the Western countries where there are definite guidelines as to when somebody with epilepsy can drive, we still do not have come out with formal guidelines. But a general thumb rule which we practice, which we have been practicing in our epilepsy surgery comprehensive team, is that if somebody is seizure free on drugs for 6 months, we permit them to drive. We kind of allow them to drive. So there's a general thumb rule. I won't say that it is based on any categorical scientific evidence, but 3 months of seizure freedom on drugs is what we generally allow.
Okay. Dr. Jitin has a question that is there any role for pre-rehabilitation before surgery to minimize the post-operative deficits or the problems encountered?
Exactly.
Counseling.
Yeah. I just reading his question in the chat box. Yes, Jitin. I mean, that's what I was. As I said in the beginning of my talk, I was a late riser in this area because initial part of our focus is always on do a good resection, to do good surgical technique, and it's all focuses on that. And the epileptologist also generally tends to focus on finding out the epileptogenic zone and handing it over to us. But then, as I said, the expectation of the patient must be the most important priority for the surgeon or for the epilepsy team. So we need to know his expectations, and then we need to optimize or customize our approach towards that. In fact, recently we had one instance where we decided not to operate on the patient when we told him that his overall outcome is likely. It was not a, I would say it was a palliative surgery. When we told the outcome was around seizure outcome, what we are planning is 40 to 50%. And then he said that was the least of his concern. He was okay with medicine. He had a lot of other memory problems and so forth, which he wanted. He wanted to know whether he will get back to work with that and so forth. So we decided against surgery. So pre-rehabilitation, but for the other patients, like especially as you said, the vision problem, the memory problem, the attention problem, these are three important problems, which, and of course the uh, suicidal tendencies some of them have. Of course, there is no way to pre-assess and know that some of them, which of these patients are going to have a suicidal problem post-operatively. But good amount of counseling before taking them up is very important. And this rehabilitation in terms of verbal memory, which Jitin has mentioned, is very important, especially for the left side. So the neuropsychological evaluation helps us to determine, and then we need to start off with a pre-operative speech therapy counseling session just before surgery. That definitely helps in the outcome. The last question about inpatient rehabilitation preferred to outpatient rehabilitation, I guess won't not needed. Inpatient won't be required. If they can outpatient, it's almost the same. But getting the entire team is so immediate post-operative period. If you have the entire team around, that is much better. Outpatient rehabilitation, because I said the team has so many members, getting all of them on board together on the same day might be difficult.
Dr. NG को in कर देना. Dr. NG would like to give some inputs. Dr. NG CN, would you like to give some inputs regarding the questions displayed?
Thanks, Amit. And thanks, Dr. Girish. That's an excellent lecture. I'm actually speaking later, but I thought I'd just answer some of these questions first because they're very fundamental to rehab. So to Jitin, I think there is some evidence for prehabilitation, not so much in epilepsy, but in major surgery, right? So there are many parts of the world, people do give prehabilitation for 2 or 3 weeks to improve function or improve the resilience before they undergo major surgery. And I presume it's going to be the same for epilepsy as well. And because a lot of people who are epileptics or have chronic diseases tend to be frail and have many comorbids as well. So by giving some prehab, the hypothesis is that we actually improve the underlying reserve and such that they actually do better after the surgery. The second part is psychological outcomes for patients. And I think it's very important to stress that certainly there are return work programs in many parts of the world where they match the requirement of the job to the actual strengths of the patient when it comes to rehab. So it's important as well. And together, I mean, collaboratively can work on some of these protocols as well. The third is shifting vital functions, right? So unfortunately, when we shift vital functions, normal areas of the brain, the recovery tends to be worse. So there are now studies looking at how we can actually map the correct parts of the brain to actually plasticize the brain to have better outcomes. And I suppose the last question I wanted to answer was, are there predictors of rehab outcomes after epilepsy? And generally they are. But the first thing when we ask about outcomes is exactly what outcomes are we referring them to, right? So there's cognitive recovery, there's motor recovery, there is recovery to return to work, for example. So generally, people which have surgery which is more limited to more generalized, of course, have better outcomes. And I think it's not so much predictors, but the actual training goes into rehab, which actually predicts better outcomes as well. So for example, if you want to get a person back to work as a laborer, you would train them to become a laborer rather than giving them very generic exercises as well. Whether it's inpatient, outpatient would depend on the center. What we often say is that the initial part where plasticity is at the maximum, we actually keep them inpatient, get more intensive rehab, and after 1 or 2 weeks, they can be charged outpatient for outpatient rehab as well. So that's my 2 cents worth of rehab, and certainly can talk a bit more later.
Thank you, Professor CN. Thank you, Professor Girish. Now I would...
Ahmed.
Thank you.
Thank you, Dr. NG.
That's a great talk, Dr. Girish, and thanks for supporting rehab as well.
We had a nice
Yes.
round of discussions too.
Thank you.
So the next speaker for the day, may I welcome Dr. John Solomon M. He is Associate Professor, Senior Scale, Department of Physiotherapy, again from Manipal Academy of Higher Education, State of Karnataka, India. He would be talking about rehabilitation following severe traumatic brain injury. Professor John.
Thank you, Dr. Amit. Thank you, Dr. Sinha, and the team of World Federation of Neurosurgical Societies for giving me this opportunity to talk on this platform. Dr. Amit, am I clear?
Yeah, please could you make it in the presenter view, your presentation?
Yes, yes, yeah. Fantastic. Yeah, I just should see it.
Thank you.
Thank you. So there is going to be two talks on TBI rehabilitation. And I know the next speaker is also going to talk on it. So I'm going to focus on some specific areas in rehabilitation of severe traumatic brain injury. And before that, we'll just briefly look at the concepts or the why the rehab and what is the impact. When it comes to traumatic brain injury, as we all know, it's one of the leading cause of mortality and morbidity, and it has a significant effect on the socioeconomic losses across in India as well as in the world. Nearly 20 to 50 million people suffer from non-fatal injuries, with many sustaining disability as a result of injury to the head. And often it is the very young age group between the age of 20 to 40 that we majorly see who undergo who are suffering from the TBI and require rehabilitation after that. It is estimated that nearly 1.6 million people sustain traumatic brain injury and close to 2 lakh people succumb to death every year, and over 1 million survivors require rehabilitation. And you can, as we know, traumatic brain injury results in a sequelae of problems, which includes disorders of consciousness, sensory motor dysfunctions, autonomic dysfunctions, cognitive, perceptual, behavioral, and communication disorders, as well as dysphagia. So this requires a big team of members coming together and working together. So TBI rehabilitation requires interdisciplinary model or interprofessional practice where the patient becomes the center of the care, and we have quite a number of professionals, starting from a medical practitioner to social worker, and not just the health professionals, often the other family members and friends, and sometimes even engineers come in hand in helping in the rehabilitation. For today's talk, where I'm going to talk on the rehabilitation of severe traumatic brain injury patients, I'm going to focus on two aspects of this. That is about early rehabilitation. One, it is a well-established fact that it is important to start mobilizing the patients with TBI at the earliest, and also to work on improving their arousal and to improve their motor and functional recovery. So I'm going to talk about two of our studies that we conducted in our center. One related to mobilization, the other one related to improving arousal. The first study is on where we focused on developing algorithm or a guideline to work on mobilizing patients and to test how it is working on patients with severe in patients with traumatic brain injury. It was taken up as a student project by Mr. Mishri, and Dr. Girish Menon is one of our co-investigator, and we wanted to look at how mobilization should be taken up after the traumatic brain injury. When we talk about mobilization, we are talking about either in-bed mobilization as well as out-of-bed mobilization. In-bed mobilization focuses on general movements, passive movements, active movements, stretching, other facilitatory techniques, all of that can be done on the bed, and to an extent even propping up also. But when we say the out of bed mobilization, we're thinking about shifting the patient from the bed off to another mode, maybe to a wheelchair or a tilt table, or if the patient is more conscious, we're talking about more about supported standing and assisted walking. Uh, there are many modes of it, like so as I told, it could be using a wheelchair, making the patient, taking them out, or giving movements, or making the patient stand on a tilt table and so on. But to do that as early as possible, how early can we do it and how carefully we do it? We wanted to develop a guideline for patients with, for mobilizing the patients with traumatic brain injury, and we wanted to test its feasibility and how it influences recovery of these patients. So first, we did a 4-round Delphi method of consensus. We had a set of experts across the field. We had neurosurgeons, neurointensivists, internal medicine except cardiac neurophysiotherapists and neurophysiotherapists who were mainly had experience in dealing with acute TBI patients and had more than at least close to 10 years of experience in this. And what are the major suggestions that came up? Where one, treatment options, we base it on different levels of consciousness, those who are conscious and those who are unconscious. And what are the red flags for mobilization, and when you should be cautious? What are the precautions to be taken while mobilizing, and when you should stop mobilizing, or the termination criteria? So we say during the rounds, 4 rounds, initially we sent out asking them what all the criteria they think are important, and then we sent out, after collating everything, we sent to all the experts, and we asked them whether they agree or not. Then based on, we looked at agreement and pulled the data, all the data. The ones that are not agreed, we took it out, and then finally we came with certain set of criteria, and that's how this guidelines was developed. And here, when it comes to red flags, these were the conditions that were considered due by the experts. One, if in case of cardiovascular, heart rate less than 50 or more than 120 beats per minute, or blood pressure less than 90, systolic blood pressure less than 90 and more than 160 millimeters per mercury, or diastolic blood pressure less than 60 and more than 100 millimeters per mercury, or mean arterial pressure less than 60 and more than 110 millimeters of mercury. If these vital signs were if it is within the range, can be considered safe to be mobilized out of the bed. Now, this does not restrict them from doing any mobilization within the bed, even though if there are variations in this. If the patient had a recent myocardial infarction and it showed the ECG shows a unstable ECG rhythm, or if the patient is having an acute DVT or pulmonary embolism, the patient should be avoided to mobilize outside the bed. Similarly, patients who are not maintaining oxygen saturation and are dropping below 90 without support, if you have to take them off, then you have to avoid mobilizing them outside the bed. With the mechanical ventilation, when you are trying to make the patient stand nearby outside the near the ventilator, then you need to be careful that if the FiO2 is more than 50, if more than 10, and if they are taking already spontaneous breaths less than 8 breaths per minute, or if they have a irregular breathing pattern, it should be avoided. Similarly, neurological red flags, ICP more than 20 millimeters of mercury, and any other signs, or if there is no monitor, and if there are signs of increased ICP with dilated pupils or pressure trial, and also if there is a CSF leak, then the patient should not be mobilized. Similarly, when there should be musculoskeletal, if there is an unstable fracture of spine or lower limb fracture, then mobilization out of the bed should be avoided. While moving, there should be appropriate precautions. There should be adequate manpower to mobilize the patient, and there should be ensuring when they shift the patient to the tilt table or to the wheelchair or trying to make them move around. That should be they should ensure that check for the presence of lines and then ensure it is not getting stretched. If there is an EVD, it has to be clamped before mobilizing the patient. And if there is a recent episode of seizure, you have to be careful. Check for any patients, any palsy, or if the patient is not cooperative, as deteriorated, you should wait for it. And care should be taken while handling the area of suture or the craniectomy defect. And especially also similarly while shifting the patient, look if there is any subluxation, the care should be taken. Or when there is also craniectomy, the cranial flap when it is kept in the peritoneal cavity, lifting and shifting should be careful and should not bend the patient too much. Wherever necessary, in case of spinal injuries, spinal orthosis should be involved, or care should be taken if there is any fixator for lower limb fractures. In case of patients who are in RLA stage 4, who are agitated and aggressive, uh, precautions should be taken in shifting the patient, be careful so that the health professionals are not affected. Termination criteria that came up were that whenever if the patient during the mobilization starts having an abnormal breathing pattern or shows any signs of increased ICP, then the mobilization should be terminated, or if they enter into any one of the red flags that has been already mentioned, should be also terminated. If the patient's heart rate increases than expected 20%, or if there is a significant postural hypotension and other similar criteria. Now, what we wanted to do was we wanted to check if it really works. So we tested for a period that is from December. We had a control period in which we had conducted. We were mobilizing patients as we were doing before. We didn't really fix the criteria, and in phase 2, in the next from December 2016 to February 2017, we followed all the criteria and mobilized the patients. And we took a sample of the 37 in the control and 27 in the experimental. This is not an RCT, so it was based on the time period. And we looked at the patient outcomes of Glasgow Coma Scale, Disability Rating Scale, Glasgow Outcome Scale, and we also looked at length of hospital stay. And we noted down if there is any effect on adverse effects to mobilization. So what we found is that though there was no significant change with GCS, but there was a significant difference when it comes to disability rating scale. And there seemed to be a reduction in the length of stay with a mean of 1.5 days only, but when it comes to they were mobilized earlier with the criteria. And so during that, we could say that we did not come across any adverse effects, and the guideline-based mobilization was found to be safer, and it looked like it could improve the functional outcomes and early discharge. But we needed a larger trial to establish this effect. So this was one aspect where we have a clear criteria and safely mobilize the patients after traumatic brain injury. The second one is focusing on their arousal, that is to improve their consciousness. There are many methods that are being tried for improving arousal level. This study where we wanted to test meaningful multimodal sensory stimulation in patients with coma following traumatic brain injury. This was taken up by one of our, again, a postgraduate student, Ashish Shah, with whom we developed a set of methods. Now, why was this method needed? Majority of the patients, when they are in coma, the recommended methods are to use a multimodal stimulation. But most of the studies do use the stimulation as an individual stimulation. For example, auditory separately, visual separately. There are tactile stimulation given to the patient. So individual stimulus, even some of the guideline of that particular multimodal stimulation says, don't give multiple stimulus at the same time. But the brain usually doesn't perceive stimulus separately, but it always relates to the context of with what the sensation is being delivered. So we wanted to develop a model in which the inputs are given in a such a way that the stimulation is combined with a functional task, so that the patient feels and understands the sensation that the patient is receiving. Hence, we operationally defined meaningful multimodal sensory stimulation as a process in which we give multiple meaning stimulus in an integrated manner that adds salience to the patient. So we wanted to test its effect, and this was a pilot RCT that was conducted in between July 2017 to January 2018, and we had 10 patients in each group, and we purposefully took the sample based on certain criteria. We included patients between the age group of 18 to 65 with GCS less than 8 or equal to 8, and who are hemodynamically stable, like stable vitals, and are out of ICU, and has a minimum of 48 hours after the traumatic brain injury or after a surgery. We excluded if the patients had any previous brain damage or had a known impaired vision or hearing, if they had any active autoria or rhinorrhea, and patients or persistent vegetative state not caused by TBA, or patients with autonomic dysfunction or any fractures, we excluded them. And we took the approvals we had registered CRI, and investigator one administered the treated protocol, that as the primary investigator was administering the protocol, and there was a blinded assessor from the same batch who took the outcome measures, which were coma recovery scale revised and the sensory stimulation assessment measure to check for how the patients are responding during the coma during the stimulation program. And these were recorded at the time of recruitment on the 7th day and the 14th day. So basically we took the informed consent from the third party, and then we also ensured if wherever patients recovered from coma, if there was a provision for reconsent. The patients were, after screening, if they fit into the criteria, they were randomized into control or experimental group using a SNOS method with 5 blocks of 4 chips each. And the control group received the conventional coma arousal technique, where we delivered stimulations on an individual basis. That is, each stimulus was provided one after the other. Whereas in the experimental group, this was an example of a farmer who had a grape wine vineyard. So basically, we give the, for example, take one task, take a grape, ask the patient to open the eyes, make the patient visualize it, make the patient feel for it, tell about it, talk about it, make the patient caregiver ask them to remember things related to the particular thing related to the object that you are showing, and use the same for olfactory stimulus or even gustatory stimulus if required. So you take one task and use it for a multiple stimulus that are meaningful in such a way that will link to the patient's salience, will create salience. Now, in control group, when we gave each stimulus was given between 5 to 15 minutes in multiple gaps, without so that at the same time avoiding that the patient will go in for accommodation. Whereas in the experimental group, each treatment session lasted for 45 minutes with multiple tasks that in which the patient had to hold it, move it, feel it, and listen to things about it, like that. So each of the duration of the treatment was same for both the groups. That was 45 minutes twice a day for 2 weeks. We involved one of the session was delivered by the caregiver, whereas the other 2 sessions were delivered by the therapist. The outcome measures, as I told you, the coma recovery scale as well as the salience scores were taken at the time of recruitment, 7th and 14th day. then we used a Friedman's ANOVA and Bristol-Walensky test were used to compare the scores of both the scales, and we kept a p-value of 0.05 as significant. Now, this is the demographic characteristics of the participants, and the mean age were around 40, and you can see most of the patients, most of the things were comparable between the groups, both the groups. And when it came to comparison of the coma recovery scale, the scores were at the first time of recruitment were almost similar, but in the experimental group, the scores significantly improved compared to the control group, and the score of close to 5 difference was there, which is also considered clinically significant. And when it comes to the SSAM score between the two groups as well, similarly, there were a significant difference between the groups. The responses were relatively much lesser when it came to the control group, whereas the responses when it was given with functional input, with a meaningful multimodal stimulation, the responses from the patients were high. Though there are subjectivity to these both the scales, this has to be explored further. So in this study, we found that this is a more safe and feasible way of incorporating coma stimulation for patients with coma. But to know its effectiveness, we again required a larger RCT, and I suppose my student is taking up a PhD to the next level to explore it. So these are the two main things that I wanted to talk about. One related to mobilization, and the second one is related to improving the arousal level. So to summarize, early mobilization can be initiated in patients with TBI carefully by following the guidelines for mobilization. And by using a meaningful multimodal sensory stimulation, it may improve the arousal level well in patients with coma. And what is more important is to have an interdisciplinary team to work on all the things, both in mobilization as well as in sensory stimulation. You need not only a therapist, but also the caregiver, nurses, and others to involve themselves for delivering these services. The other one is, the last one segment was that caregiver education and training is very important, and this has to be started much earlier, so that when the patient gets discharged, they can deliver most of the treatment at the home. So with that, I conclude my talk, my acknowledgements to my colleagues and my students and the experts and all the my institution for their support. And thank you once again for.
Thank you, Dr. Solomon, for giving such practical inputs into rehabilitation of TBI patients. A couple of questions. The first one is that, do you do multimodal stimulation only for the first 2 days or throughout the study period?
Yeah, it's throughout the study period for the 2 weeks.
Okay.
Every day, try 3 times a day for 2 weeks.
And any
So that is
advice?
what we had done. But I think, sorry.
Yes, please continue.
Yeah. So otherwise, the thing is, because our study was limited, we had fixed it for 2 weeks. It was given only for 2 weeks. But if the patients stay longer, this program can be extended further as well. But it is at least given at least 3 times a day, 45 minutes of sensory stimulation program for continuously. There are programs that run for 6 hours and 8 hours also through the day. But there are mixed results with those that have been more stimulation and as well as less stimulation. But we find a stimulation program between with short gaps spaced across the day are more useful and practical.
Do you have any advice for improving the dysphagia in many of these TBI patients?
Okay, I do. I mean, in our team, we have a speech language pathologist who deals with dysphagia, but we do work with them. There are a couple of things as physiotherapists we do it. Is one of the main thing is posture. Also, is one cause for dysphagia in patients with PPI, especially with tonal abnormality, where they have a protracted and extended neck. And in this posture, you try to swallow even saliva, you can't. Even a normal person cannot do it. It's very difficult to swallow the saliva. So working on a posture, getting the appropriate posture right, getting the chin tucked, so that the gustatory system is in line and easier for the patient to swallow. And there are stimulation techniques, oral techniques that activates the swallowing. And there are patients who have severe bite reflex, dangerous patient. So you need to be very careful on working on reducing the bite reflex. There are inhibitory techniques that are used to reduce the bite reflex, and also based on the type of feeds that are given, starting with semi-solid, then gradually to solids as well as then to liquid. So the mode of giving the feeding also matters. So again, that requires a teamwork. Both PTs as well as speech language pathologists work together in this for improving swallowing.
Dr. Jimmy Joes has a question that how do you rehabilitate patients in RLA4?
Okay. So it's a very tricky patients group. So you don't go, usually the patients are aggressive and it's very difficult to fit your time and their time. So in these patients, you have to be very flexible. You need to see what is that they are willing to do. One of the things is they're going to have a very short attention span, and they going to get very irritable. So always what you do is you give them a choice. Do you want to do this or do this? Go with their choices, and don't prolong the therapy time too long. It has to be pretty short. Keeping them in relatively more silent room with less distraction, and also ensuring that there are no bright lights or irritable things that the patient may get easily irritated. So you have to tailor it to the patient's mood and the time where they are more cooperative, and keep the sessions as short as possible, and try to work on things that they are interested in. So that would be one of them.
Another two short questions. Dr. Jitendra has a question that what is your opinion about role of music therapy in enhancing the arousal mechanism of the brain?
I have very less experience on it, and I haven't worked with music therapy yet. But I'm sure that it's a very interesting area, and there are art studies that are coming from. I have read a few articles, and even in one of our IFNR sessions, there was a session on music therapy and arousal. But I'm sorry, I am not the person for that. I have less experience.
Professor Sinha has a question, the last question probably, that do you have a separate protocol for pediatric age group patients?
No, not really. We don't have a separate protocol, but I think many of the we developed the protocol for adults. When we set it up for adults only and for youth. But many of the things that were developed in consensus, the criteria, most of the factors will also fit in pediatric group, except for certain vital signs that has to be adjusted according to the pediatric age group. So I think it's still open. That is something that we could work on and develop separate criteria for pediatrics.
Okay. The actually questions are flowing in. So
yeah, I will try to answer some of it during the next talk in the comments itself as much as possible.
Fine. So
I'll do that.
So we will get on with the next presentation. Thank you, Dr. Solomon.
Thank
you for the nice presentation. Over to the last speaker of the day, Dr. Ng Sien from, he's a senior consultant in rehabilitation medicine, Singapore, General Hospital, Singapore. Dr. Sien, please could you start your presentation?
Right. Thanks, Amit, and thanks, Prof. Sinha. So my talk today is on, I'm glad I'm not overlapping with the previous speakers, Dr. Girish Solomon. So my talk today is on challenging cases of in TBI, or traumatic brain injury rehab, right? And I'm going to focus on something which is probably the most challenging aspect of TBI rehab, and that's agitation. And if there's some questions previously on agitation and how we actually rehabilitate them, this is classically what we know as Rancho's Los Amigos stage 4 or grade 4, which is confused and agitated. It's even worse in the elderly because it's really very difficult to restrain them. You can see this person, which obviously has traumatic brain injury, is actually restrained. He's actually in a vest. It's a common problem in every country as well. So again, these patients are consented to photograph, but please don't spread the photos around too widely. But it's a big problem, agitation and delirium. But before that, I would like to thank Prof. Sinha, which I know for a long time. This picture is of the Neurotrauma Society of India, which we presented more than 10 years already by now. And I'm just amazed at the community spirits of people with traumatic brain injury and spinal injury in India. And a lot of the education in trauma of the brain or the spine actually goes out into the community. And these are challenging times because of COVID-19. And I hope once COVID-19 is over, we can come together again and share best practices. But thanks again for inviting me, and this webinar is actually excellent. Okay, back to agitation and delirium as well. I like to divide agitation in two kinds, right? The first is primary agitation, or those agitation due to TBI itself, which accounts for about 30–60% of people with TBI, of moderate severe TBI. And if I just show you quickly these videos, you can see, but it could be a bit jerky. This is a person who is obviously in agitation. He's raising his arms, he's looking around, he is trying to claw a bit, he's going to bite a pillow soon, and we have to restrain him really badly and get him back to bed itself. And, you know, look at him, he's biting his pillow, and his bed, right? Right. But I mean, in ideal situation, once they recover, they're like that, right? They get very calm and they're not agitated anymore. And what rehab tries to do is bring them from a state of this to this as well, right? So that's what we try to do when we get people who are agitated through rehab, getting them from an agitated state to somebody who is a bit more calm and more collected. It's important to see the pathophysiology of trauma and why people become agitated. And there are two main reasons, right? The first of which is, if, for example, there's a contact injury, you go forward and you just bang your head, people will hit their temporal lobes, their frontal lobes especially, and the occipital lobes through a contractile kind of injury, right? And once you hit your frontal lobes, the frontal lobes are the center for behavior, for executive function. Many people will get agitated. So that's the first principal mechanism for injury for people with TBI. And then, as we know, there's the acceleration disaster injury, or what results in diffuse axonal injury, right? When the head moves and suddenly stops, the brain is like an egg in eggshell. It spins and spins and spins. And then you lose consciousness. They get DAI of many parts of brain, including the white matter. And that can give rise to a lot of agitation as well. So there are many reasons why people get agitation, principally because they injure the frontal lobes through contusions, and then they end up having diffuse axonal injury with impacts on a conscious level, and this clouding or brain fog of consciousness and become agitated. What's important, and in our center, we use measures of agitation. This is a common one that all of us use, as the ABS, or Agitated Behavioral Scale. People do divide agitation into three parts. One is aggression, one is disinhibition, and one is lability, right? So aggression is, for example, you try and pull out tubes all over the place, and then you score it something, right? Disinhibition is when, for example, you take out your clothes suddenly in a ward, right? And that's disinhibition. Lability means you keep changing mood all the time. And all this forms the agitation construct. And agitation is it's more found in people with frontal lobe injuries, people who are younger, and of course, people who are depressed or suicidal previously as well. So it's important to chart agitation because it serves as a tool of communication, both for baseline interventions, whether it's medical or non-medical. And I think it's important as previous speakers pointed out, to actually measure what you're doing. For example, using DRS to measure disorder's consciousness as well, so that when you give an intervention, you can see improvement, right? Agitation, as you know, is a multimodal way to approach. In summary, quickly, these are the 5 medications that we use to treat agitation. My favorite is propranolol, actually. This old drug called propranolol is a beta blocker because it's effective. It's not many side effects. And I go up all the way up to like 20 to 30, 3 times a day to actually control agitation. And it works wonders actually quite well. Other drugs I use includes antipsychotics or sometimes anti-epileptics, sometimes methylphenidate as well, and sometimes amantadine, right? Each drug has its pros and cons, many side effects, and it's often a balance of what you think is going on with the patient, right? So the patient is very excited and disinhibited. Sometimes propranolol is slightly better. If the person is at risk for injury, whether to self or other people, usually the antipsychotics have faster onset of action, which is visible, right? So often we mix and match drugs according to the profile of what a person is actually in. Of course, the other things can do, apart from medications, there's this idea that you fatigue the medication out by, I'll tell you what I mean. As Prof. Sinha has pointed out, I think education to the family and to the team is very important to explain that agitation is often a transient process that people start from a totally disorder consciousness, a vegetative state, to somebody who is actually, it's just a transient process. But what we try to do in the hospital is some environmental control as well. These are some rooms we designed for people with agitation. You can see these kind of rooms. The bed on the ground, they have padded walls, and the floor is padded. The window is really high up, so you can't jump outside. And there's a CCTV as well that monitors people from outside. So this person can, it's probably safe to move around. And this is along the lines of we fatigue out the agitation to get people tired out from all this, and hopefully that helps them along the lines of recovery. In the US, for example, they use these things called veil beds so that you don't have to restrain a person. Restraining a person is sometimes you have no choice but to restrain it, but often the best thing is just to let go of restraints and let the person trash around inside a veil bed or in a controlled, what we call a traumatic brain injury agitation room as well. So that's something to think about if somebody's going to design a traumatic brain injury center. But what I'm going to do now next is present you 2 cases of agitation to tell you that sometimes the challenging problem of agitation is not just due to brain injury, it's something else, right? So let's go through cases, right? So this is a 70-year-old Chinese male that came into a department. He had very poorly controlled diabetes, unwitnessed head trauma. He was admitted to the emergency with GCS of 12. It's moderately severe brain injury. He's very restless and aggressive, right? He was admitted to hyperdependency ward, and I think some neurosurgeons, because of what we'll show you later, started him on Capra or levetiracetam for a week or so. These are his initial scans. On the right, you can see the lung on the left is white out. He actually had rib fractures and a collapse of his left lung. You can see the CT, there's actually an occipital fracture on the top right. I can't put a pointer. Right. So there's a fracture of the occiput behind. And these are the CT scans of his brain, right? And you can see the CT scans of the brain. There's SAH or cerebral hemorrhages, mainly in the front, a lot in the frontal lobes, and you can see blood in fissures as well, together with the occipital scalp hematoma. So this guy has extensive frontal lobe contusions involving his brain and SAH as well. So it's no wonder he's agitated, right? Because the front is affected, and that's where all the emotions and all the behavior is. The temporal lobe is affected, so that's usually where things like memory, emotions are affected as well. And overall, the occiput is affected, and this guy actually had visual hallucinations to a big degree as well. But what I'll show you later is quite interesting, right? So he was admitted on 23rd of March, actually this year. He remained mostly in Ranchos 4, agitated, and his ABS charts on the right side, right? So we charted him on the ABS and the scale was 32, just to know that 32 would correlate to someone who is moderately agitated. He actually eats without supervision. He's able to walk around with drunken gait, but required 2 people to assist him. And the first lesson that I would ask everybody who manages TBI is when you see a person agitated, don't always presume it's due to brain injury. There are other reasons as well. So we did a big workup for electrolytes, blood sugar levels, and sepsis. And we cleared the cardio as well. I just show you his electrolytes to show something that people might miss, right? So the one key and what he pointed out was actually he kept asking for this ice cold beer and water all the time. And it keeps pointing to the cupboard in the fridge. And just to show you that in this case, agitation do something else, right? In traumatic brain injury, you can see sodium levels. You can also see 3 phases in sodium level. One, the first phase when his sodium levels was low, he actually had moderate agitation. The second phase in red, when the sodium level was high, he actually had very severe agitation. And the third green column, when the sodium levels went back to normal, he actually had very little agitation, right? So the sodium levels actually mirrored his amount of agitation. And it's quite interesting, and we actually submitted this for case report. So let's go through the first part where they actually had low sodium levels as well. He could participate in physio and occupational therapy, but he was not focused and needed restraints. So we decided to work out his low sodium levels, right? And we actually, you can see the lab results in the box. His sodium levels were low, and he had, high urine sodium in his urine, with normal serum osmolality and normal urine osmolality. And this comes to the first common issue when it comes to managing TBIs in the ward. The first question we always ask in TBI, right, is this SIDH or is this cerebral salt wasting? And there was a time when surgeons were very interested in this idea of cerebral salt wasting. You can see the lab results, they don't really fit SIDH because the urine and serum osmolality were more or less normal. They are not high, for example, in urine osmolality. So it fits a bit more cerebral salt wasting. And if you see the literature, right, there's a lot of talk about cerebral salt wasting in the literature. And for his case, he didn't have any criteria for SIDH, although it looked like SIDH. He was actually dehydrated, and his lab findings were supportive of cerebral salt wasting. And he also had bilateral frontal and temporal SAH and frontal contusions as well, which gives even more weight to this person might have cerebral salt wasting. And so, like good physicians and good rehab people, the interventions for SIDH and cerebral wasting were different, right? So we decided to hydrate him rather than restrict his water. Because SIDH actually treat by restricting water. We just hydrate him with a lot of normal saline. Because of the following reasons, he was dry, he was thirsty, and the urine sodium was high as well. And we treated, and actually it got back to normal. But that's not the end of the story, because a few days later, although his sodium went back to normal, it started climbing up and climbing up really, really high to above 165. And that's really high sodium, right? Can die from that kind of hypernatremia as well. This time he became very, very agitated. He required restraints. We started on propranolol and quizapine, and then olanzapine, which are antipsychotics and beta blockers, but nothing seemed to work, right? We not only did that, we actually gave him a lot of dextrose. We actually switched the normal saline to dextrose 5% because of this high sodium. And despite giving 1.5 liters and then 2 liters and then 3 liters, the sodium in the blood remained high and remained very agitated. We did some calculations on dehydration, and indeed he was both dehydrated as well as very agitated. So the first point I'm bringing up to you now is that, again, agitation is not just due to the brain injury itself, but it can be due to issue. And this issue is recognizing increasing frequency, and the question is this: what is the underlying etiology in this case? And the thing that we have to consider is this, right? We have to consider whether this person actually has central diabetes insipidus or DI from post-trauma, right? And indeed, I'm running out of time. We work this through quickly. And we did a trial of what people call DDAVP, or intramuscular desmopressin. And through calculations, this person we confirm had diabetes insipidus, right? You can see when we give IM-DDAVP or desmopressin, the urine started concentrating. And so based on criteria, for example, he had polyuria, a high sodium, a high serum osmolarity, a low urine osmolarity, and response to DDAVP, this person actually had central diabetes insipidus, right? Which brings up the next question, right? When we confirmed that this person had DI, he wasn't thirsty at all. And there's this thing called adiposic diabetes insipidus, which is actually a possibility in which this person actually sustained trauma, not just to the pituitary, but also to the hypothalamus as well. Because as you can see, the hypothalamus is above the pituitary, is where the thirst centers are. And if you actually injure that, a person will not have any sensation to thirst, and he might be polyuric from losing a lot of ADH because of his diabetes insipidus. So we decided to actually scan or try to scan his pituitary with CT. We couldn't find anything. We wanted to do an MRI as well, but we couldn't do the MRI because the person was so agitated, it kept moving around. But indeed, I think we have confirmed this case that this person had agitation, not just from brain injury, from diabetes insipidus as well. Here's some of the lessons, right? That agitation is not always primary. In this case, is due to post-traumatic diabetes insipidus. And just know that diabetes insipidus post-trauma often happens not on day 1, but on day 13 to 14, about 2 weeks after the injury, like this person. And if you see a person who's agitated about 2 weeks after injury, do screen the electrolytes for diabetes insipidus. And it's partly difficult in the person who have TBI because it requires a lot of nursing resources to let the person drink freely. But it brings up the next problem of that when we manage TBI, both medically and rehab, we have to be really conscious on screening for pituitary dysfunction after TBI. And in acute phase, we're concerned about 2 things. One is diabetes insipidus, and the other is disorders in the ACTH cortisol axis as well. So a person who has low blood pressure or low sodium or high sodium, I think the 2 things that we are concerned about is whether we should screen them for hypocortisolic state or whether the person has diabetes insipidus as well as reasons for trauma. So this is a lesson I'm trying to bring to you, that do screen for this, right? Both long-term and acutely after brain injury. Can we move to the second case? This is a 56-year-old Malay male who lives in destitute home. He's a schizophrenic, he's also diabetic, he's also chronic alcoholic. He was referred for a fall and he had a short attention span and was very distractible, and his ABS score was 30, right? It was compounded by underlying schizophrenia. Another case, right? As you can see, this person has a oral gastric rather than a nasal gastric tube because of his fractures, which I'm going to show you here, right? So his CT scans show that he actually has acute subarachnoid hemorrhages in frontal lobes. You can see white spots where the frontal lobe are. And he also had a subdural. You can see the hematoma on his left frontal lobe outside the skull. And you also have stable acute subdural hematoma on the right cerebral convexity as well. But this person who has diffuse subarachnoid hemorrhages. And what he also had were fractures of the skull base, right? So he had problems with the middle CT shows a depression in the pubiform plate. And around the orbit, he had many fractures as well. In ethmoid sinus, sphenoid sinus, the walls of the orbit canal, the roof, etc. So he had very bad, he had skull-based fractures of his brain. So he underwent TBI rehab and significant cognitive impairments in many of the domains of rehab. He required moderate assistance, but he still had this branchial 4 agitation as well. He was pulling out tubes. You can see in the photo that he was actually being restrained by hand restraints as well. We started on quetiapine and benjexol, which is artane, which sometimes it's anticholinergic, might help with agitation as well. But it went through some time with this, right? And he never got better. Then one day, all of a sudden, on day 3 weeks after rehab, he suddenly went to shock. He was bradycardic, he was hypotensive. He was given 5 liters of fluid and blood, but he went to shock from systolic blood pressure 120 to 85, and he was very drowsy as well. He was transferred to high dependency intensive care, and despite giving him adrenaline, dopamine, and atropine, he will still remain in shock. And we started on some broad spectrum antibiotics as well. So like most people, when we go into shock, we try to find the cause. And we scan his whole body, and there were no focal signs or anything else except in the brain. You can see the CT. The CT shows that there's some bright spots in the brain. And the neurosurgeon suggested MRI of the brain. And on MRI brain is what we saw. We just saw this, right? And the neurosurgery people were right that what you actually see in the brain as a cause for agitation in this case is enhancing well-demarcated brain abscess, which is causing agitation, right? So we went this, lo and behold, he went to shock because he had brain abscess, post-traumatic brain injury. And we switched antibiotics to ceftriaxone, rocephin, and patient was stabilized. We wanted to aspirate his brain, but the surgery and rehab people said, wait a bit first. And once we started antibiotics, he got better, right? So the second lesson to teach everybody or get very aware is that post-traumatic brain abscesses can also present as agitation. And it's usually open fractures, but closed fractures can happen to this as well. Remember, frontal lobe abscesses are more common, followed by the parietal lobe. It can happen sometimes with a brain injury. In traumatic brain injury, some reports of brain abscesses. Staph aureus and epidermis are probably the most common. In this case, for example, because there's a base of skull fracture, organisms have gone through that and invaded his brain, causing abscess. But just remember that brain abscesses are another cause of agitation, which is not due to primary brain injury. Second lesson I learned, right? So another challenge in rehab is agitation. Right, so this guy is moving, he's much better now. It's a bit slow, but he's got better, right? My last thing I'm gonna bring up, because I know it's getting on, is this question of, do we do rehab in people who are agitated, right? And the question is, how intensive can we push a person who's agitated? So as previous speakers have pointed out, I think rehab is important, particularly as Dr. Solomon has pointed out, early locomotion or mobility is important because neuroplasticity is greatest due to TBI onset, and also we have to reverse all these effects of deconditioning. But there's one difference between how we rehab a person with TBI compared to a person with stroke. And that is when we rehab a person with TBI, implicit memory, which is the memory used to walk, things don't forget, how to drive, how to walk, how to run, is intact. Whereas explicit memory, which is stored in the frontal and temporal lobes, are affected. So when we actually do rehab for a person with TBI, we actually get them to do functional motion and cyclical motions rather than breaking up the steps, because the people with TBI have problem breaking up steps. I'll just show you a case of how we rehabilitate this guy with TBI. 65-year-old male, he had witness fall, and he was given diazepam, and he had very severe brain injury. His GCS was 6 in ER. This was the CT scan, which shows subdural hematoma and generalized brain edema. He had surgery for it. He had bowel evacuation and insertion ICT monitors. And what you see are clips here. This is a pneumocephalus from the bowel, from the ICP insertion. His cognition remained poor. His rehab functional scores remained 18. Film score is very poor. We started amantadine. Somebody asked previously on whether you give drugs for people in DOC, and amantadine is the one that we usually start with, apart from methylphenidate. And just show you some quick videos, right? This person is, when the person is in TBI, he's very restless. He's actually moving around, right?
Good morning.
All right, I'll just forward this because time's running short. And this is how he walked. You can see the way he walks. This is a person with TBI walks. They don't really have focal deficits, but they walk around like a drunken person. And this guy requires 2 people to walk him. he doesn't know where his steps are. This is my physio's doing TBI rehab. So as you note, right, he freezes his gait. There's more rigid steps. There are a lot of people with TBI have problems with balance to getting better. But you get the idea that TBI rehab, you don't actually try to break down the steps, but get them to walk. Then the next step, we ask ourselves, right? Can we put this guy on bodyweight support training or robotic training, right? There are some papers that have come out from many centers and including some of our centers as well, to use locomotor training or robotic training when it comes to TBI rehab. And generally, what we say is that we try to do it if we can. And I don't have a photo here, but we actually put this guy on a robot. Do I have this photo here? Yeah, sorry. To get this guy walking. And after that, we did get him much better. And this is him now. And this is how is he walking now, right? Okay. So I'll show you the video later because I missed it out in the original photo. Right. So it got much better now, right? And if I could quickly share you my photo on what robotic training looks like. Give me a minute. I'll bring it up. This is what's sorry, just give me a quick minute. Right, this one. Yes, this one, right? So if you can see my screen, sorry to share this, show the screen, right? So if you see my screen, this is robotic training. So you can see this person's a robot. You can see he's moving his legs like that now. And this robot provides a lot of repetitive training. So what we do is we train people to do cyclical motions on a robot, and this is an end effector robot, and it's actually quite useful. And do consider doing something like that if you can. And of course, after robotic training, it's actually much better, and he's actually walking around in the community now as well. So right, so it's much better now, right? So so I would like to, sorry, you can see it's my, hold on a minute, right. So it's much better now, and he's walking. Okay, it's like, right. Right, so it's walking much better now, although he's still, shuffling a bit like that, but he's walking much better than he was and doesn't require support. So my lesson in this case is that even if a person is agitated, try to give rehab, because rehab and upright position and circular motions are important for recovery, right? So that's where I come from. Just to finish off, this is my hospital where I work. The Singapore General Hospital is one of the, probably a lot of the best hospitals in the world, and we have 1,800 medical beds, and we have a nice rehab center. So if anybody else wants to visit us, please let me know, and I'm glad to show you around. We have a new rehab ward as well in our center as well. So in summary, agitation in brain injury is common. Do assess it with validated instruments, such as the Agitated Behavioral Scale. Treatments, combination of medications, education, and environmental control. All patients' agitation should be thoroughly assessed for secondary causes. In this case, look for diabetes insipidus and brain abscesses. I think intensive rehab is safe in TBI patients with DOC and agitation, and may improve cognition as well. We advocate for bodyweight support training, whether it's a robot, no robot. And I think the main last point is to combine modalities to help people with TBI, as well as, I think at the end of it, as Prof. Sinha has said as well, always involve the family in setting goals realistically, and to get them back to society. All right, thanks so much. Right.
Thank you, Dr. CN, for such an impressive presentation. Especially the last video was very, very nice to see the robotic training for gait.
But it's not always like that, right? Just showing a success story. It's not always successful, but we try our best.
Yeah, but it was very inspiring to see that.
Thank you.
We have one question. This question is from Dr. Shahnawaz. He wants to know that what measures do you take if neurogenic bladder develops due to frontal lobe or paracentral lobule injury?
All right, that's a good question, right? So I think, first of all, when a person comes into our unit, we routinely screen them for their post-void residual urine. So nowadays, rather than an in-out catheter, all of them, when they come as a protocol, almost like a protocol, they will scan the bladder ultrasound, whether it's actually residual urine. And if there is, the first thing we try to do is to reverse all causes, right? What we find is that the main reason for neurogenic bladder or incontinence after brain injury is not often from just the injury itself, but from other factors, for example, immobility, constipation, medications. Many of the medications can cause incontinence as well. And what we often find is that if a person has neurogenic bladder and there's a lot of bladder retention, the first thing we do is we do a time voiding program, right? So in every 4 hours or 6 hours, we get the person to try to pass urine, whether you can or cannot, just try to pass. And failing that, if we really cannot, and there's a lot of urine, then we either teach them to do intermittent catheterization or indwelling catheterization. So that's the first thing we do. But of course, we will screen them for other secondary causes like whether they have urine infection, whether it's due to constipation or mobility. That's why when Dr. Solomon talked about early mobility, one of the reasons why I do that is actually to reduce the incidence of incontinence or neurogenic bladder. Next question is that, of course, when we give propranolol, we need to monitor the pulse rate. I think the baseline about 45 to 50 at a minimum pulse rate to give propranolol. But often my experience is that when you give 10 milligrams or 20 milligrams TID or 3 times a day, the pulse rate never falls very much, and it's usually quite safe. So I've almost never had an experience when I even give doses that you give for thyrotoxicosis with about 40 TDS, and the blood pressure drops precipitously. So it's quite safe. And propranolol, we do monitor pulse rate, of course, but I've hardly seen it drop below 50 either as well, right? As to yes, I think in terms of what you brought families when we conduct a study, yes, I think that is really answered as well. Keppra itself can produce agitation sometimes. Any epileptic medication can paradoxically cause a change in cognitive level as well. I think Keppra is a lot safer than the old medications like phenytoin, valproic acid, or carbamazepine. But having said that, we also use anti-epileptic drugs to control agitation. It's just that I've never used it very much because there's also evidence that the usage of anti-epileptic medications actually retard or actually inhibit recovery after a brain injury. So we tend to keep it very short, and if agitation occurs, we probably use something else like propranolol, anti-epileptic, or even amantadine or methylphenidate, rather than using an AED, right? So that's some of the things that we think about TBI rehab. Can you diagnose DAI in patients with GCS and 8 above? I think when you talk about DAI, there's the clinical diagnosis and there is the imaging diagnosis, right? So in clinically, DAI without a focal brain contusion or brain injury tends to follow the stages of the Rancho's Los Amigos. It means a person who has DAI will probably start off with a very low level conscious state like DOC, sometimes progress to an agitated state, then it enters a state of confusion or disorientation, and then it states the state of more normality, right? So a pure DAI patient will probably progress through that stage. And if a stage where a person journeys from a state of poor conscious level to agitation to a more normal level but still confused, you can pretty certain the person has DAI. the only way to prove DAI, apart from histology, is to do MRI studies, right? CT scans often miss DAI because by nature of the fact that CT scans pick up bone better and not tissue very well. MRIs, at the current high resolution MRIs can pick DAI much better. And I think the move towards brain injury MRI is people using MRIs to actually predict recoveries from studying functional connectivity in the brain through things like diffusion tract, DTI, as well as resting state networks as well. So to look at DAI, probably somebody has to look at MRI of the brain. But MRI, it's easier said than done. And the person was agitated. We couldn't do the MRI for this person because the person was crashing away. And sometimes, the value and the benefit may not actually be the best thing to do the MRI.
Thank you, Dr. Sen, for the nice presentation. And in fact, with this, we come to the end of this wonderful webinar. We had 4 esteemed speakers. Now I request Professor Sinha for the closing remarks. Professor Sinha.
Yes. Thank you for. Thanks for all the speakers for this very informative lectures. And I want to thank Dr. Angelo, Dr. Grishmanan, Dr. John, and Dr. Angisian. And we know that 30% of the patient of the neurosurgery, they have some form of disability. And what is the answer? Rehabilitation. So we should have more. Best part was all the participants, they were staying from beginning to last, same number. So thank you again. Thank you. Now we should leave. Thank you.
Thank you.
Okay,
thank you, sir. Thank you.
Thank you.
Thank you.
Bye-bye.